A very good afternoon to all of you. And I'm going to show you this particular gentleman. I hope some of you might recognize this chap. Can anybody tell me who this person is? Someone in the audience, please? Yes, please? Yeah, correct. He's none other than the Napoleon Bonaparte, the French conqueror. So, as you can see, he is keeping his hand inside the jacket. So, has anybody thought about it? No. So, many historians say that he used to keep his hand inside the jacket. One good reason is to show his strength and power. So, during that French era, that is how people used to show their power. But another unknown reason is he had a stoma inside, which he used to care for. So that is something. But I would like to remind his famous quote, which I also like, which is, if you want a thing done well, do it yourself. As I started a bit of history, so let me dig into the history of stomas. So number one, the first ever recorded stoma that was surgically created or constructed was in 1710. That was on a dead child with an imperforate anus. The surgical colostomy was created. And then a few years later, about nearly a century later, a live child was subjected to a surgery with an imperforate anus, and then a colostomy was created. And then in 1851, a urostomy was created. Later in 19th century only, first ever ileostomy was created. But the ileostomy didn't gain popularity because of its notorious complications that occurred following that. But however, in 1952, the everting techniques or the spouting technique was demonstrated by this Babe Brook, the famous surgeon, and then the ileostomy kicked in. So, let me ask this next question: what is a stoma? So, this is the definition of a stoma: is a communication, natural or artificial, between a body cavity and an external environment. So, I hope some of you would agree or argue with me why then the mouth becomes a stoma. Yes, it is. As some of you would agree or know that stomodium, where the embryological origin of the current day mouth has originated in the embryo, in the mother's womb, is called stomodium. So the word stoma arises from there. So there is a slight difference between this stoma and ostomy, where stoma is natural or artificial, whereas ostomy is a surgically constructed stoma or the communication, where we give this term colostomy, ileostomy or urostomy. So today's discussion is mainly going to be on intestinal stomas, although some of you may have questions about urostomies and other types of stomas, but I will answer those questions if the need arises. So there are various types of stomas that we know about, and based on the bowel type that we construct the stoma on, we call it ileostomy, if the ileum is brought out as a stoma. Or if the colon is brought out as a stoma, we call it a colostomy. Based on the permanency, or if there is any plan to reverse it, we call it a temporary stoma. Whereas if there is no plan of reversal surgery, we call it a permanent stoma. However, some of the temporary stomas, unfortunately, or fortunately, for some patients, turn out to be permanent stomas. I hope some of you would agree. And based on the bowel arrangement, if the single end of bowel is brought out, then we call it a end stoma. Whereas a loop of bowel is brought out and there are two openings in single stoma, we call it a loop or double barrel stoma. Next, I am going to discuss the indications or instances in which some of the common stomas are constructed. First, the end ileostomy is what I am going to discuss. End ileostomy is usually constructed when the whole colon is removed for a cause, such as there is a condition called familial adenomatous polyposis coli syndrome, where the whole colon is studded with polyps. There are hundreds and thousands of polyps in the colon, which, if we leave, is going to be definite cancer. So in such instances, we do not wait until those polyps turn out to be cancers. We just take the whole colon out and put the patient on an end ileostomy. And there are similar conditions like HNPCC or Lynch syndrome. And if there is fulminant ulcerative colitis or Crohn's disease, we tend to remove the colon. In such instances, we construct an end ileostomy. Otherwise, we tend to construct a loop ileostomy in common practice. That is to defunction. This word might sound alien to most of you all. That is to rest the distant bowel. The most common instance in which we construct a loop ileostomy is to protect a distal anastomosis. Most often it is when we do an anterior resection for an upper rectal cancer, where we remove the cancer and we anastomose the colon and the rectum, and to protect, that is the very easiest way of putting it, to protect the anastomosis or the joint that we surgically constructed, we tend to put an ileostomy to protect the anastomosis. And next is to relieve the distal obstruction if it is unresectable. So I told you in the beginning, this is the reason why my mother was given an ileostomy during that time. She had an unresectable ovarian carcinoma and she was given an ileostomy. So, and in other instances where the patient was offered a loop ileostomy is to defunction in fistula or in rectal trauma or in patients with incontinence, right? Anal incontinence. So in colostomies, end colostomy, that is could be in a permanent scenario. For example, in a patient with lower rectal cancer, we tend to remove the whole anorectal region, the whole system, including the sphincter complex, where we tend to bring out the large bowel as an end colostomy. And in a Hartmann procedure with an intention to reverse the stoma in a later date, of course, and in fecal incontinence. A loop colostomy, and again to relieve distal obstruction or in fecal incontinence, or in some instances as an emergency in an anastomotic leak. Okay, so I won't go into intricate details of the surgical principles and surgical construction, as this may sound very boring to you all, but I will briefly discuss the basic principles of this intestinal stoma. Carrying a stoma on a patient is a very stressful thing to have. So the patients must be counseled pre-operatively, that is prior to surgery. And also the patient should be consented, informed written consent should be taken prior to the surgery. The marking of the stoma should be undertaken before the surgery. And the marking should be done in the following principles should be adhered to. Number one, first and foremost thing, it should be marked pre-operatively. Patient should be dressed in his or her normal clothes, and it should be away from scars, skin creases, and bony prominences, and it should be visible to the patient. But you might wonder why this phrase appears, because some of the obese patients, their large abdominal panels might hang, and then they might not even see the stoma, then they might have to find it difficult to find the stoma. So it should be visible to the patient. And the stoma marking should be done in the standing, lying down, and seated positions as well. So during the surgery, there should be no tension, and there should be no tightness of the abdominal wall opening, and there should be good blood supply of the bowel, and should be tension free, twist free. And I will briefly discuss about the complications, and finally I am going to conclude the session with stoma bag and the stoma care products and applications as a video. So the complications, unfortunately, 1/3 of the stomas have complications. So, and a good number of them will require revisional surgery. So I'm going to discuss these topics under early, late, and ileostomy specific complications. So early complications, one common or dreaded complication would be ischemia and necrosis. So most common in colostomies than ileostomies. The reason being, most of the people in the surgical practice would know extensive skeletonization of the bowel is one of the prime reasons, and there may be tight abdominal opening, and there may be large abdominal panels in an obese patient. The management is certainly revisional surgery. And stomal retraction, the stoma that is going into the abdomen, so that is again a problem. So that is again due to insufficient length of the intestine or inadequate mobilization of the intestine. So there are other reasons as well. Again, if that is present, if that is causing significant morbidity to the patient, we will have to offer revisional surgery. If that is the stoma that is inside the abdomen, if that twists and causes obstruction, then again that's a problem. We'll have to offer revisional surgery. So there are certain late complications that we will have to look into. One is parastomal hernia. So that occurs in about 30% of the cases of mostly in colostomies. So mostly the patient might complain of a pain, and there can be a swelling around the stoma. I will show you a picture later. And the most often the patient complaint would be the ill-fitting stoma appliance. The base plate or the wafer that we apply on the stoma might not fit properly. So that is the most common complaint the patient has. And the management is a mesh repair, as we do for any other hernia surgery. So this is the picture that I was talking about. I'm sorry. So next is stomal prolapse. So the bowel, some of you would have seen rectal prolapse. The rectum is protruding through the anus. So similarly, the bowel can prolapse through the stoma. So this is again a complication, late complication of stomas. So this is most often seen in transverse loop colostomies, as in this diagram. So that is the reason is if the large bowel is hanging and floating in the abdomen, and that tends to prolapse. So the management would be, if that is not causing significant problems and if it is not a recurrent problem, then we can apply hypertonic saline, or some even apply sugar and let the edema settle in, and then gently reduce the prolapse. Or if that is causing significant bleeding or ulceration, then we will have to offer surgery or revision. If that is stenosing and causing bowel obstruction, again surgery. Then there are certain complications that are specific to ileostomies. This is very common in ileostomies because of the problem that I will discuss later. Irritation, ulceration, skin disformation, and abscess formation. So mostly this is due to because in ileostomies we know that the ileostomy fluid that comes out tends to be more irritant in nature. That is, it has a lot of bile and enzyme rich, and it's a caustic nature. So this tends to ulcerate the skin. So the management is proper construction of the stoma, and we have to provide proper stomach care nursing, and well-fitting stoma appliances are in the market. We have fine and skin barrier creams. So these are the common problems that we come across in ileostomies. There is peristomal skin ulceration and irritation, and there can be the chance of stoma retraction as well, if that is so severe. So this is a very uncommon situation, peristomal fistula formation. As in perianal fistula formation, there can be peristomal fistula formation. So this is common in Crohn's disease. So this is the prime target of today's lecture, proper application of stoma appliance. So these are the types of stoma appliances that are available. So ostomy products, we have skin barriers. We call it the base plate that we apply onto the skin. So we call it wafer or base plate. There are bags or pouches, and there are accessories, powders, pastes or belts. So I will talk about each of these products later. So this is a skin barrier. So this is something that we apply onto the skin. So we call it base plate, no, in our practice. This has what we have in our hospital is a cut to fit product. So we can cut it to a specific size that we want. So there are pre-cut wafers or base plates as well, which we don't have in our country. And there are flat wafers which we have. There are convex wafers or the base plates. There can be if the stoma sits on a gutter, there are commercially available base plates which has a convex appearance, which we can apply directly onto the stoma. So there are base plates that can sit in the stoma for a long time. Especially if the effluent is so liquid and watery, then we can keep it for a long time. So those are extended or long wear products. And pouches, the bags that we apply onto the base plate, that is one piece or two piece. If that is a one piece bag, then it has a base plate on it. If it is a two piece, we have to stick it onto the base plate. So it can be closed or drainable bag. So if it's a closed bag, then you have to throw it out. If it's a drainable bag, we can open it underneath, and then we can clean it, reapply it. So the closure options, what do we have? We have a clamp, no? Like an umbilical cord clamp. We have a clamp there. So that is a common thing that we have. So there is a Velcro mechanism as well. We just roll it and then we apply the Velcro. So that way we can minimize the odor, the smell of the stoma. But unfortunately, what we have in this country or in the government sector does not provide that sort of a protection. So accessories, powders, we have this stoma skin powder, or there can be antifungal powders as well, which is available in the market. And there can be deodorant drops we can apply into the stoma bag, and that can minimize the smell, odor. And then these ostomy belts, not many patients use it, but that is a very helpful and thing to have. If you apply it across the waist, that gives a lot of courage and comfort to the patient, so that patient can proceed with his day-to-day activities. And this stoma paste, so I would like to with this notion, because this is not an actual adhesive or a paste. It's just a sort of a cement like. It's just to fill in the gap, not a paste. It's not a gum or sort of a thing. It's just to fill in the gap to apply the base plate on the skin. Okay, for a better fitting. So what do we have? All that is left. We are left with is this a stoma pouch or the bag on the upper corner, and a clamp and a base plate and a belt. And that is something that I want to show you here is this white color thing. What is that? That is a stoma measurement guide. Okay. Now let's watch this video and come back to the same slide again.
Changing a pouch. Your entire one-piece and two-piece drainable pouch will need to be changed every 3 to 5 days. If you see any output or leakage around the pouch, or if you feel any burning or itching under the barrier, change your pouch right away. Just how long you can wear a pouch system depends on how full you allow your pouch to get, how much you sweat or perspire, and how smooth or uneven the skin is around your stoma. Decide on timing. You'll also need to decide on timing pouch changes. For a urostomy, you will always be producing urine, so the pouch and barrier can be changed anytime. Gather supplies. Changing your pouch system is much easier when all your supplies are handy, so the first step is gathering everything you'll need. A new pouch, something to clean your skin, such as a damp washcloth or wipes, a sizing template to measure your stoma and size the opening, a pen to trace the size of your stoma, scissors for cutting the opening, and a small disposable garbage bag. Though you may not need them, other stoma supplies include skin powder to place on red, weepy skin, skin paste or rings to fill in any folds or gaps, skin barrier sealant to coat the skin so the barrier sticks better, and adhesive remover. Most barriers will adhere to the skin with no additional supplies. If your barrier is not sticking, talk to your doctor and ostomy nurse to help you problem solve. Remove the old pouch. To remove the old pouch, begin by peeling away one corner of the barrier. Then work around the rest of the barrier, pushing down on the skin at each point, while at the same time pulling the barrier away from the skin. Some people use a cloth or gauze to push on the adhesive as they remove the barrier. Lastly, place the used pouch into a disposable waste bag. Clean and inspect the skin. After removing the old pouch, look at your stoma and check the color. It should be red and moist. Also, check for any bleeding. This is rare. Then, check the skin around the stoma for any redness or irritation. Your skin should look like the rest of the skin on your abdomen. After inspecting your skin, clean it with water and a washcloth. Do not use scented soaps, oil, or alcohol. Then gently pat your skin dry. If the skin around the stoma is irritated or weepy, you can apply some skin barrier powder to absorb the moisture. Remember that your new barrier will not stick well if your skin is moist. Measure and cut the opening. Next, measure and cut an opening in the fresh barrier. Most skin problems are caused by the ostomy opening not being cut to the right size. So it is important to measure the stoma and make sure you have the right fit. So, let's do this together. You will need the stoma practice model, pen, measurement guide, scissors, and pouch from your skills kit. Measure the stoma. Use your sizing template and determine the size of your stoma. You should be measuring your stoma practice model. Find the size that fits closest to the edge of the stoma where the skin and the stoma meet. Next, place the template on the back of the pouch barrier and trace the correct size. Use the scissors to cut an opening in the barrier closely following the traced shape. If you're using a one-piece pouch system, place your finger into the small pre-cut opening and push away the pouch before you start to cut. Be careful not to cut through the front of the pouch. If you do cut the pouch, do not try to tape it closed. It will leak and also emit odor. Center the new opening over the stoma to make sure it fits along the stoma edge. For the first several months, your stoma will continue to shrink in size as swelling goes down. So in the beginning, you will have to measure your stoma with each pouch change to make sure you have the right size opening. After that, you'll be able to pre-cut your pouch opening from your template or order pre-cut pouches. The opening should fit very close to the edge of the stoma to prevent skin irritation. If your stoma isn't perfectly round, work with your ostomy nurse or doctor to make a custom template. Applying the new pouch. Now you can attach the new appliance. Start by removing the paper from the adhesive back of the barrier. In this case, we have inner release paper that gets removed first and outer release paper that gets removed after that. Do not remove the side tabs. Next, center the cut opening over the stoma. Place the barrier on the skin around the stoma, hold it in place, and press down on all sides for about 30 seconds to make sure that it is firmly applied. Then, in this case, remove the adhesive side tabs. Now, raise the bottom of the pouch and close the opening. Some people wear a pouch belt to secure the pouch. You can date and keep the paper from the back to use as your template for the next pouch change. Okay, so let's pause as you measure, cut, and apply your pouch to the ostomy practice model.
It's the video produced by the American College of Surgeons. So let's answer this question. So out of these things that are in the stoma box that we have, the least used yet the most important item. Can you answer the question? Yeah. So this is the most important item but the least used. So let's use it to have a better stoma appliance. So that is the message that I want to give. So things you need a measurement guide, base plate, scissor and a pen. And you measure the correct size using the measurement guide and then you cut it. Suppose you have a stoma on a patient which isn't a perfect circle. What are you going to do? So if you look here, in this you can see there is a ruler in the upper end. So you can use the ruler and make a oval shaped marking on the base plate, and then make the incision or the cut in the base plate, and then use it to make the cut, and then cut the base plate. And then before application of the base plate, we just keep it on the stoma and then check whether it is of the appropriate size. How big are you going to cut? What is the gap you are going to leave? Just 1 millimeter, not more than that, not less than that. Just 1 millimeter is adequate. Okay, and then you apply. Okay, if you leave too much of skin in between the stoma appliance and the stoma, what is going to happen? Whatever the effluent that is or the fluid that is going to come out through the stoma is going to irritate the skin and going to cause problems. So next time you are going to change the appliance, you will have to face problems. Okay, right. So when to empty the bag? I have seen patients hanging a bag full of stuff, hanging like this, and going to the washroom. So that is not the case. You empty the bag when it's 1/3 full. You can wait in desperate conditions to let it half full, but not more than that. 1/3 is the way forward. So the take-home message: we look for complications and treat when it's necessary. Let's let's not forget the stoma measurement guide and use it appropriately. And don't cut the base plate too bigger than the stoma, and empty the bag when it's 1/3 full, and refer to the surgical tape whenever it's necessary. So thank you very much for your kind patience and cooperation. So the forum is open for questions.
The day-to-day life, bathing, washing and other things?
Yes. Yes. That's a very good question that I anticipated. So of course I prepared a slide and I didn't want to have it on the lecture, but I'll show it now. So this is the slide that I prepared anticipating this question. So this is living with stoma. So what are the things that you can do and you can't do with stoma? So basically physical activity, you can do anything, but bathing, yes. But if the effluent with or without the bag, you can have a bath, no problem. Because the stoma base plate or the stoma appliance is a hydrocolloid appliance that is very well stuck to the skin. So it is waterproof, so no problem there. You can have a bath, no problem. And swimming, no problem. And how about physical activity? Yes, you can have workouts, all that, but the problem is if the patient is having too much of perspiration or sweating, then that might be a problem, because that might lead to ill-fitting stoma, or else it might lead to regular change of stoma appliances. But having said that, in patients who are having who are involved in sports activities, they can certainly continue their sports activities, and but contact sport is better avoided, because it might damage the stoma. And a good question that often patients find it difficult to ask and we find it difficult to answer is having sex. Yes, you can have sex, but the problem is we have to counsel the partner. And you have to tell the partner that it is perfectly safe and not a problem to have sex. And also we have to educate the partner or the patient to empty the stoma bag before having sex. But again, there is a problem. Why? Because oftentimes these patients who have a stoma have pelvic surgeries. So there is a chance that their pelvic nerves may have been jeopardized due to the surgery itself or the radiotherapy given before or after the surgery. So there may be a certain degree of erectile dysfunctions and sexual inabilities due to this surgical and other oncological treatment modalities. Given this scenario, there can be some compromisations have to be made in terms of sexual life. But certainly the patient, if the couple is happy, they can have sex. And travel, yes, they can travel. But the thing is, here of course that is not a common practice, but in abroad, they often go abroad in aeroplanes. They have to carry this stoma appliances in their carry-on luggage. And so drink, when they are traveling, they have to drink safe water. That is what we advise. So have I answered your question, sir? Thank you. Sir? Okay. सर्जरी स्टोमा का क्या करना का और इधर इवन सीट पे सारे अखंड दिन को टाइम तो लेती है लोग अभी फैशन करंट होती है ये स्टेट है कॉस्मेटिक फैक्टर्स पर फॉरेन कंट्रीज में
travel long hours, what to do? Yes,
Yes, ma'am. Thing is, it actually is. I would say it's easy for anybody with a stoma to have trouble. I would say because you don't have to actually go to a proper toilet. I would say just a garbage bag or something would be enough for them to empty the effluents and then discard it whenever the you find a place or the dump it somewhere whenever it's appropriate. So it's easy in that way. I hope you.
So what about, do they need a special dietary advisor when the patient is on stoma?
Yes, sir. There is a set of guidelines where the patient should have and should not have, because some of the stomas they produce a lot of gas. Some food items they produce, we tell them to avoid to reduce the amount of gas. Some food products they increase the liquidity of the effluent. Some thicken the this thing. So I'll provide a chart here, sir. So this is the chart that I want to show you. So the first column is the one that increases the order. So these are the ones that stomates should avoid. If what is the problem? What is the concern? So gas, if the pouch is becoming ballooned out very often, then these are the ones. These are the food products they should avoid. And if the effluent is too solid, then these are the ones they should avoid. That is too what? These are the food items that they should avoid. Have I answered the questions?
Yeah. We have to educate the patient according to the law. From motion, you have to advise the patient himself can adjust the diet. No?
Yes. Although I have put this chart, sir, most of the time the patient, him or herself, knows which item is better for him or her, although how much we tell them.
Do we need to advise them about the stoma also?
Yes, sir. That is a concern in high ostomies. That is also in the earliest few days, where the output is going to be massive, which can even lead to dehydration and electrolyte imbalances. So we have to, luckily though, the patient is going to be in the ward in the post-operative period. During that period, we are going to look after the patient, so we will deal with the dehydration and the output. Some patients, even despite after discharge, they might end up having high output state. So in such patients, we tell the patient that you might have a problem. So if that is the case, you will have to look into the fluid balance as well.
How about colostomy?
Colostomy is usually, sir, depending on the large bowel that is involved, how the stoma is constructed. Usually, if it is the left side of the colon, then again mostly it's a solid material that is coming out. So then the output is not a problem. But if it is mostly the right side of the colon, then again it might be similar to the ileostomy.
विस्तारात प्रश्न दिया ना.
प्रश्न दिया. Laparoscopy, endoscopy. एक प्रश्न है यस टेक्निक सिस्टम एक कारण बोलो एक ඇත්තටම ඕපන් කරනකොට ලැප්‍රොස්කෝපි කරන එක හොඳයි කියන මට හිතෙනවා ඒ කිව්වොත් ඕපන් කරනකොට මම හිතන්නේ සරලව ඇග්‍රී වෙයි බවල් කන්ටෙන්ට් එක කන්ටැමිනේෂන් රිස්ක් එක තියෙනවා හැබැයි ලැප්‍රොස්කෝපි කරනකොට ගොඩක් දුරට ඇප්ලයි කරන හන්ද මෙෂ් එකක් තානකොට මෙෂ් එක ඉන්ෆෙක්ට් වෙන්න පුළුවන් chance එකක් ගොඩක් අඩුයි එවිඩන්ස් එක chronic pulang karena stoma ini stoma itu asli ලැප්‍රොස්කෝපි පුළුවන්.
Stoma bags, the base plate or सामान plastic होगा.
මෙහි මස්කිලගේ
private sector करना मतलब इतना बिना private sector
ප්‍රයිවට් සෙක්ටර් එකේ මම දැනගන්නේ නිසා ස්ටෝමා බේස් ප්ලේට් එක කොස්ට් එකක් දැනට මම දන්න තරම නිසා 1200 විතර වෙනවා. ඒක බේස් ප්ලේට් එකක්. බෑග්ස් නම් ඊට වඩා ගොඩක් කොස්ට් එකක් නිසා. හැබැයි මේ ඔක්කොම කෑග් ගත්තාම ෆ්‍රීකවන්සි එක චේන්ජ් කරන සාමාන්‍යම කියන්නේ අයිස්ටෝමි එකක් නම් දවස් 5කට සැරයක් බේස් ප්ලේට් එක මාරු කරනවා. කොලෙස්ටෝමි එකක් නම් දවස් 7කට විතර මැනේජ් කරගන්න පුළුවන්. එතකොට දැන් අයිස්ටෝමි පේෂන්ට් කෙනෙක් නම් මාසෙකට අපිට 6ක් 7ක් විතර ඇප්ලයන්සස් වරනවා. හැබැයි අපේ ක්ලිනික් එකකින් අපි දෙන්නේ බොක්ස් එකයි දෙකයි. එතකොට ඔක්කොම බේස් ප්ලේට් 4යි. ඒකට පේෂන්ට් පොකට් අවුට් කරලා ඊයෙන් ගන්න වෙන අවස්ථා තියෙනවා. අදත් අපි ක්ලිනික් එකට පේෂන්ට් කෙනෙක් ආවස එහෙම ඊයෙන් ගන්න වෙන අවස්ථා තියෙනවා කියලා. අපේ ලෙවල් එකකින් අපිට සීමාවක් තියෙන අපිට කරන්න පුළුවන්. එහෙනම් මම මේ ස්ටෝමා කෙයාර් වර්ක්ෂොප් එකක් කරන්න අදහස් කරේ අපි කරන දේ ගොඩක් හොඳයි. හැබැයි අපිට කරන දේ තවත් ටිකක් හොඳට කරන්න පුළුවන් කමක් තියෙනවා නෑ. යාර දාන කේස් ප්ලේට් එක තව ටික දවසක් කර තියාගන්න පුළුවන් වුණොත් හරියට ඇප්ලයි කරලා ඒකෙන් පේෂන්ට් හොඳක් වෙයි කියලා තමයි මම මේ චෙක් කරන්න ඕනේ කියලා මට හිතෙනවා. අනේ තියෙනවා. ඔව්. ක්ලිනික් එකේ දෙනවා දෙකක් සෙට්ස් දෙකක් දෙනවා. මම මේ ඔන්ලයින් ෆෝම් එක දානකොට මගෙන් අහලා තිබුණ ප්‍රශ්නයක් තමයි යුරෝස්ටොමි බෑග් එකකදී ලීක් එක කොහොමද මිනිමයිස් කරගන්නේ කියලා. සාමාන්‍ය යුරෝස්ටොමි කන්ස්ට්‍රක්ට් කරන්නේ සාමාන්‍ය අයිලියල් කොන්ඩියුට් එකක් සමග. ඒකත් අයිලියස්ටොමි එකක් වගේම තමයි. ඒ ප්‍රොපර් ඇප්ලිකේෂන් එකක් තිබ්බනම් හරියට ඇප්ලයි කරා නම් ස්ටෝමාශ්‍රිත ප්‍රශ්නයක් නැත්නම් රිට්‍රැක්ෂන් එකක් ඕස්ටෝමිය එකක් නැත්නම් හරියට අපි ස්ටෝමා හරියට මෙෂර් කරලා ඇප්ලයි කරා නම් ලීක් එකක් වෙන්න පුළුවන් chance එක අඩුයි. යුරෝස්ටොමි එකක් ගත්තාම ඒකේ ලික්විඩ් ගතිය ගොඩක් වැඩි. බවල් කන්ටෙන්ට් එක වගේ නෙවෙයි ලීක් වෙන්න chance එකක් වැඩි. හරියට අපි බෑග් එක ඇප්ලයි කරොත් ලීක් වෙන්න පුළුවන් chance එක ගොඩක් මිනිමයිස් කරගන්න පුළුවන්. ඒක ගොඩක් හොඳ අදහසක්. මේ පිටරටවල එහෙම ඒ වගේ ස්ටෝමා සොසයිටිස් කියලා එහෙම තියෙනවා. ඒගොල්ලෝගේ ස්ටෝමා ගැදරින්ග්ස් මීටින්ග්ස් එහෙම තියෙනවා. ඒගොල්ලෝ සතියකට සැරයක් සතියකට දෙවරක් එහෙම එකතු වෙලා ඒගොල්ලන්ගේ ප්‍රශ්න කතා බහ කරලා ඒගොල්ලන්ගේ කවුන්සලින් ඒගොල්ලන් කරගෙන අවස්ථා තියෙනවා. අපේ එහෙම සිස්ටම් එකක් තාම නැහැ. හැබැයි අපි එහෙම එකක් පටන් ගන්නවා නම් ඒකට අපි සහයෝගය දෙන්න අපි කැමතියි.